Thank you. Good evening, everybody, and good afternoon to Mhoira. So, um, I know Mhoira for the last maybe some 15 years, and has had the opportunity to observe and uh, and to listen to many of her classes as a student and later uh, as a colleague and yeah. So Dr. Mhoira is uh, presently working as head of palliative care at Makerere University, Uganda. And also she is the medical director of Cardiff International Palliative Care Trust, Scotland. So initially she was trained as an internal medicine physician in Aberdeen University, Scotland. But then she specialized in palliative medicine. And she was there in Aberdeen University as consultant and honorary senior lecturer for 10 years. And during that time, there were many developments, and she was mostly included nationally with National Health Services as well as advisory and training roles for Royal Colleges. And she's a fellow of the Royal College of Physicians of Edinburgh and Glasgow. And she has a particular interest with international palliative care. And she has traveled extensively in various, and she has worked extensively in various countries, especially in Eastern Europe, India, and Africa. And even I would say that many of us would not know many parts of India, but Mhoira would know that. Then she actually in 2008, the Makerere University invited her to develop an academic unit for palliative care in Makerere University, and the National Referral Hospital to act as a center of excellence for research, training, and clinical services, and to build capacity for Ugandan and African clinical leadership alongside key partners such as Prosperous Africa, Uganda, the Palliative Care Association of Uganda, and the African Palliative Care Association. And her key achievements include development and implementation of a model clinical service, research agenda, undergraduate and postgraduate training, and support for a BSc in palliative care at Makerere University. And she usually comes to India and stays here for 2 months every year. And she do it with the partners like Palliative India and Emmanuel Hospitals Association. And she tries to develop palliative care in areas of India where it is very stark. And she's also one of the board members, board of directors in International Hospitals and Palliative Care Organization. So being said that, most importantly, Mhoira know India very well, and most of the palliative care physicians in India, and she's a very friendly person. And I know that some Malayalis, Keralites called her as Sundari Madama. That is a beautiful English lady. And so she has been very supportive, I should say that, for Indian palliative care. She has done a lot, including the palliative India. So welcome, Mhoira, and it's over to you.
Wow, Sunil, what a wonderful introduction. Thank you so much. I think maybe it was 25 years ago, the Sundari Madama, but anyway, I'll accept it. I'll accept it very nicely. So it's absolutely wonderful to be with you today and to see palliative care education is developing and to see now masterclasses running. So this is a real pleasure for me. And I'm looking forward to interacting and to learning together about HIV/AIDS. Now, I would say at the beginning, I'm not an HIV/AIDS specialist, but I have looked after many, many patients with HIV/AIDS, and I'm going to be focusing on the palliative care aspects of HIV/AIDS and signposting to you to where you can find out more information if you need it. I, first of all, want to try something. Now, I told you we were going to do some quizzes, so I'd like you to go to menti.com, either on your phone or on your computer, and enter in 18488-156, and then you will find a small quiz, okay? And it's to ask you, not what country, I think we'll say what city. Now let me go to this and we will see this. Let's see, I'm trying to be very clever, and sometimes when you're trying to be very clever, it doesn't work as well. Okay, so I'm hoping you enter that code 1848-8156 and tell me what city you're joining from. And if it works well, we'll see it coming up on the screen here. If it doesn't work well, I'll abandon this plan. See if you can do that. I've got some ticks here. Has anyone written an answer yet? Any answers yet? Let me see if I can see the answers.
Madam, call once more, please. Unknown.
Can you see it when you go on? Can you see this slide?
The slide is not visible.
No, ma'am, we are not able to answer in that website.
So you don't answer on the screen. You go to menti.com. You have to go to www.menti.com up here, and then you enter this code.
There is no
And you see
question.
if you- when you go into menti.com, there's no question. Okay, I'm just going to do a small adjustment. Otherwise, we will have problems again. That's very disappointing. It was working so beautifully before. Let us see. Okay, let me carry on just now. We'll see if we can manage a bit later. Maybe you can just write in the chat then which okay. So Sunil has introduced me very nicely. This is just a summary of some of the places that I have been to do palliative care. I've had the privilege of visiting many places in India. Maybe some of you represent those small areas I have never been, but it's been a privilege to visit from the northeast to the south to the northwest. I've also had the privilege of working in Uganda, but also places like many parts of Africa, and latterly doing a fair bit of work in the Middle East, particularly in Gaza and Palestine. So I'm hoping to bring all those areas of expertise today to this masterclass together. And I want to just find this concept that Sunil mentioned. I have a particular interest in fragile settings. These are places where either there is conflict or it's next door to where there's conflict, where there's protracted emergencies, where there may be humanitarian crises, where there could be political instability and weak health systems, and often high burdens of disease and death. And about a quarter of the population is included in that. And you can see here, although India is not a fragile setting itself, it is quite close. And you know the natural disasters that have affected India over the years. The reason why this is relevant today is as we begin to look at HIV/AIDS, as with every palliative care issue, you can see a correlation. So places with fragile health systems, places where they have been recently affected or people next door have been affected by conflict, are experiencing the most severe types of HIV/AIDS. And we'll be talking about that in a moment. So just keep this map in your mind. And this is the map really that represents where I have spent my 30 plus year career in palliative care, but also is relevant to today's talk. And this is what Sunil asked me to cover. So we will do this. We'll look at the prevalence and we'll show you quite a few graphs just to get you into the idea of what's happening with HIV/AIDS globally. And then think about the ethical issues. And lastly, we'll come on to symptom management and holistic care and some of the particularly relevant issues for yourselves. And just before we start, can we go on to homework? I think this is very familiar territory for you. This is an excellent document last year from the WHO, which really gave a great framework for thinking about palliative care. I'm sure you've covered this in your introductory sessions, where we look at it like a building that must have good foundations of policy and empowered communities. And India has taught the world a lot about empowerment in palliative care. We must have evidence-based practice. And then we have these pillars of essential medicines, education and training. And then the roof, if you like, the final bit, which is the health services. Now the roof will fall down if any of these other elements there are not sufficiently in place. But of course, this is all there for people to find a safe shelter for people with palliative care needs to benefit from this building. And this is relevant also for HIV/AIDS. There's the wonderful thing about learning palliative care principles. We can then apply it to any clinical setting. Let's have a look and see. Now, there's some excellent documents. I'm going to give you a reference slide at the end for some of these documents. But what I want to do is just sift it for you so we can see the global picture. So this is just a figure. It's quite difficult to see, but it gives us an overall view of where the HIV/AIDS diagnosis are happening, what the epidemic is looking like, and also something about the number of people that are acquiring it. And you might look at this quickly and think, okay, the biggest numbers are in the African region. And that would be true. But as we'll look at in a moment, it's actually not the area with the highest new cases of HIV/AIDS. And you can think a bit about why that might be the case. So here's it by region. So you can see there, people living with HIV/AIDS by region. Africa is the highest number by far. I'm going to ask you a question now then. Where do you think is the fastest growing region for HIV/AIDS? You put the solution in the chat if you know it. Where is the fastest growing region for HIV/AIDS? Any suggestions? You've got the regions up on the screen. Choose the fastest growing region. Can you do that? Anyone going to put into chat? I hope you're all familiar with how to use chat. We'll use it quite a lot in the session. Africa, America, thank you, Africa. Excellent, some good suggestions there. Africa. So most of you are thinking it's going to be Africa. Let's just have a look a bit more and see what we can find out. Globally, each year, 24% increase. Now, that is the total number living with HIV/AIDS. In fact, that rate is less than it's been in previous years globally. Okay, still with me? So actually, there are 52% less deaths. And to some extent, it's difficult because the population is growing, isn't it? But per population, we are seeing dramatic changes in HIV/AIDS. I came into palliative care in the early 90s. It was at the peak of the HIV epidemic. And I had to learn how to do palliative care for HIV/AIDS in the absence of any antiretroviral agents. Now we see a huge change and we see many, many less deaths and it becoming much more of a chronic illness. However, there are still 650,000 deaths per year, and many of those, of this 38.4, I'll show you figures later, but at least 12 million are estimated to need palliative care, not just the end-of-life care patients. You'll get all these slides, so don't feel you have to write all of these figures down. So I then wanted to ask you this question, but I think we're not going to manage it. So I'm going to ask you to put it in chat. Which global populations do you think are the biggest number, the biggest risk, or where do we see the highest number of new HIV infections, the type of populations? This is not a country now, the type of populations. So let me see. Let's see what you're writing there. And as you're writing in the chat, I'm just double checking our Mentimeter to see if there's any way it can help us now. Okay. What answers do we have? People using drugs, lower income groups, migrants, poverty, undernourished. Excellent. Excellent. Excellent answers. Thank you. So here's the 2021 figures. So many of you mentioned these populations. So a significant number in these high-risk populations, but perhaps slightly unexpected for you. So these isolated groups, and some of you gave me very general groups like those who with poverty or undernourished, but we tend to think of it as a disease of people with certain lifestyle habits and certain relationships. But in fact, the majority are acquiring it, 30% in the general population, and 25% it's because they are clients or partners, and very small numbers, but very significant numbers from these other areas. Okay, well done. It's across the disease spectrum, and as we'll see at the age spectrum, as we'll see later, in fact, children, palliative care in children globally represent a big number in HIV group. Okay, now, some of you may have heard of this, but what was decided some years ago was to aim for what's called 90-90-90 and then 95-95-95. That is to have people who know that they have HIV, their status, who are on treatment and who are virally suppressed. Okay, so countries are meant to be looking at this, and particularly areas with high numbers. How can we look at this so that people know their status and they're on treatment and they're virally suppressed? And you can look at these documents and just see where countries are in relation to these figures. Many are struggling to get to this. And we haven't got to the 95 yet. It's just the 91 that is the one we're looking for at the moment. But there's still quite a significant gap. There have been some really major successes, and I'm showing you these figures of mother-to-child transmission. In the early days of HIV/AIDS, people were thinking there is no way we can have children. There is no way we can be in a discordant couple. And that had massive implications on people's lives. We can see in this one area, for example, largely due to prenatal care and antenatal testing, we can see huge reductions in some areas where there's, in Europe, they don't even test anymore, but huge reductions in preventions of mother-to-child transmission. But you're in Southeast Asia, most of you, and you can see there's still a significant problem there, as there is in other parts of the world. And again, this is a complicated slide, but let me help you look at it. This was looking at COVID-19. So how did we wanted to look at what's happening currently. So what we saw here is that many things were disrupted. You can see at the bottom here, when it's either red or orange, it means 20 to 50% disruption. So you can see in TB diagnosis, HIV testing, some people were saying there was going to be more deaths due to the TB and malaria disruption than COVID-19. Very interesting, isn't it, when you weigh up the public health? It doesn't mean we shouldn't have approached the pandemic, but these unforeseen consequences are actually very serious as well. And people who are well established on the ARVs who may have that disrupted. And that actually is only showing some improvement. So if it's green, then you're back to pre-pandemic levels. But look at that, sort of 40% to 50% impact still on things like HIV prevention and malaria prevention and hepatitis B treatment, TB diagnosis. It's actually still 70% away. So we're living in a time where we may see some of those numbers that you just looked at really changing in the future because of the disruption of something like a global pandemic. And if you go to this really excellent document, these are produced very regularly. This is one of the best I've seen, July 2021, very recent, which is a whole spectrum of looking at HIV/AIDS. It's got indications, it's got guidelines, it's got details of medications. And this is where I suggest you go if you want to look something up about HIV care and treatment, because we will be focusing a little more on the palliative care aspects. But chapter 6 is where chronic care and palliative care is specifically mentioned. It's a small chapter, but it does say some important principles, and I'll share some of those with you. And there's also a lot of references, so you can go and find the papers and look them up. So I would draw your attention to this single document as one of the most useful if you want to understand the total pandemic and how approaches should be done. Can I also say, when I look at these documents, I'm always so impressed by the standard and the rigor. And, you know, I really want to pay tribute to those who have focused on HIV/AIDS policy and planning. And I think in palliative care, we've done a good job, but we can also learn from our colleagues in HIV/AIDS medicine because they have really approached this in a very, very systematic way and made a huge difference on a very devastating illness in a matter of decades. Okay, so ethical and legal issues. Again, I was going to play my little quiz, but instead of doing that, I want to ask you. So we'll back to the chat again. What do you think are the ethical and legal issues affecting those who are living with HIV/AIDS? For those who are infected by HIV. We sometimes call these people living with HIV, PL. You'll see me doing that, PL living WH. Disclosure, thank you. Hospitals might not treat them. Yeah. So discrimination in their treatment, issues around confidentiality and disclosure, social acceptance. Thank you, Bindu. Yeah, privacy. So I think confidentiality is something you're mentioning quite a lot. Yeah. So who decides who discloses? How is that done? What is the role we have as healthcare workers? Excellent. Any other issues that you feel are important for us to think about? Okay, that was a pretty good list. There is something called critical enablers that is talked about in the WHO document, and I want us to begin to think about this. I listed a few. You've mentioned this one, stigma, and how stigma relates then to prevention, because you don't enter into preventative practices, sometimes because of stigma. Treatment exclusions, which you mentioned, I just mentioned one there, the very expensive amphotericin B is not available in many places. Access to care, and particular concern to many are reproductive rights. I mentioned before the feeling that this was not relevant for HIV/AIDS people. Discrimination you've mentioned, but I would take that one stage further and look at criminalization. So I'm going to take us through just some of the things that have been done to address this, but also I want us to get into a discussion about some of the principles that are listed as critical enablers, things that can make a difference, and think about what they're like in our settings. Again, pay real tribute to the HIV a global community who took on activism very early on. It was initially such huge stigma and discrimination, and this was from the beginning part of the issues. And you see here some of this phrase that has become enshrined in all of our thinking, nothing about us without us. And that was a phrase that was used over and over again. And again, I think has really catapulted us all into thinking about how we involve people living with an illness in all of the aspects of that illness, including the policy making and the leadership. Let's go through some of these issues. Good practice statements. Here's the first one. Laws, legal policies, and practices should be reviewed or revised in key population groups. Maybe any thoughts as to what that's like in your setting? I'm seeing a few. I'm looking at the chat now. So think about, is this law okay? Do you think there's any issues for you in your setting? Or do you think there's still some problems? And as I look at this, I'm realizing there were a few more points. Thank you. Benita, you talked about family caregiver support, very important. And you talked about the children, very, very important. AIDS orphans, wasn't that phrase we used a lot in the early days? And you talked about denial of rights to education, great. Okay, good. So Saravani, you're picking up that most of our laws do not involve key stakeholders. Really, really significant, important, thank you. So maybe the laws are there, but they've been made without stakeholders. Do you think there's any laws that need changing in the settings you're in, revising or reviewing? So review the role of stakeholders. Anything else? And if you don't want to talk about your setting, you can think globally. If you've heard of things in other settings, that's absolutely fine to talk about that. So you're not so sure about that. Okay, let me take it one step further then. Because I mentioned it was not just stigma, it was actually decriminalization. So here's an interesting list if we think globally. Decriminalization of behaviors, because by criminalizing the behaviors, it further isolates those communities, particularly by those affected. Because remember, the criminalization is sometimes those who are abusing or pushing certain behaviors. But if you criminalize the behavior itself, rather than the criminal aspects about it, just think about what happens to those populations and therefore the implications for them ethically. So thank you, Ravin Kumar. You've mentioned about community dialogues not happening, very important. Disclosure is a real issue, and we're going to come on and look at that in a moment. What do you think about this criminalization? Can you think of any examples of this that you know of, either in the settings you're in or internationally? So not just stigmatization, but criminalization. Thank you for all the comments you're making. I'm really enjoying the fact that we're able to be as interactive. So thank you for that. Any thoughts on criminalization? Okay, thank you, Paro. So they're not approved in India. So therefore the carers may not have the status that they should have. Therefore families may not accept or allow certain lifestyles. Therefore it may delay people coming for help or may prevent us supporting their carers and their communities in an appropriate way. Thank you very much. Very good point. Suicide was once punishable. It's many parts of the world, it has huge stigma attached to it. I work in Gaza and it really goes against Islamic law. And so it's very difficult for people who are in a devout or themselves are devout to talk about suicidal ideation. Very important. Great. Legalization of caregivers, hugely important if people have chosen a lifestyle that is different from the norm in their culture or society. I work in Uganda and it often hits the headlines. Headlines for it's a wonderful place and there's many great things about Uganda, but along with many other countries, particularly in sub-Saharan Africa, but not just there are very strict laws around homosexuality. And quite recently in Uganda and other countries, criminalization of being homosexual. You don't even have to be doing anything, just by identifying with that community. And anyone who doesn't report that could themselves maybe be guilty of this law. Now, this law has not been fully passed yet, and we hope and pray it doesn't get passed. But you can see how it's very difficult then. And I agree with you, Kevin Kumar, the boundaries is difficult. It is difficult. But I think the thing that the WHO is asking countries to do is to think about not criminalizing the behavior, but maybe criminalizing, for example, the drug dealer or the person who is abusing sex workers. Yeah, it's a tricky one, isn't it? And that's why I want us to think of the ethics into this level of legal issues as well, because it's quite a crucial one if we are to be advocates for HIV/AIDS patients. Okay. Let's look at a few more. So what the WHO asks people is to go one step further. So we've said about stigma, and now we've said about criminalization, and now we're talking about protection. So when somebody is affected by these issues in a vulnerable population, what are we doing to protect them? Now, this is not just HIV/AIDS. Think about the pandemic. COVID-19 pandemic. Think about the doctors who were hounded from their homes and who found that their neighbors didn't want to know them anymore and were even attacked, and patients as well. I remember with HIV/AIDS, I remember a community in India, this is many years ago, and I hope it doesn't happen, but maybe it does, where they did not want the person to be buried on land nearby. the idea that it would somehow contaminate their water supplies. And I saw this also in Africa with Ebola. We saw it with COVID-19. Frightened populations can really respond in ways that means we need to protect people. And thank you, you're making a very good point here that the neurobiology, the whole issue of substance use, we should not, it is an illness. Blaming the person who is affected by this is not the answer. Yes, there's criminal issues around about it. Some people say decriminalizing actually allows you to then deal with the criminality of money laundering, for example, or abuse using other laws, but not criminalizing the behavior. Great, I think you've really understood this, so thank you. And we come back to these good practice statements about involving people in these planning and implementing that statement, nothing for us without us, and really seeking how we can prevent. And the problem is some of the rhetoric, some of the stigma is reinforced in many, many different ways. And that means it's even less likely that people will say that they're afraid and the violence is not prevented. Okay, excellent. So thank you for that. I'm going to take you into a scenario now. Are you ready to discuss a clinical scenario with me? So the scenario I want us to discuss is a very typical scenario in Africa. Now, I know many of you don't work in Africa, but I think that's fine. I want you to just imagine the situation and see what you would do. It's a very typical situation for me. So you're working in a regional hospital, but it's a low-income setting, and there's high prevalence of communicable disease and rising levels of non-communicable disease. This is a very typical scenario. You can do quite a few tests locally. You can do malaria, hepatitis B, HIV, full blood counts, and some basic liver and renal tests as well, and x-rays and ultrasounds. And again, many parts of the world, access to investigation is limited. You can also do CRAG. Now, CRAG is a specific test to look for the cryptococcal antigen. It's been made a big difference in finding this out quickly. So you're able to do that, but everything else, you've got to send people away. And it's 6 hours by road. It's pretty difficult. The area is rural, semi-rural. You're in a large town. It's got a lake. Most people are living subsistence agriculture on fishing. But many struggle to afford healthcare, even though there's some improvements in the socioeconomic status. You also know that there's a lot of myths around illness. People don't come to hospital to very late with all of their illnesses. And you struggle with that. Okay. So I'll just give you a moment to internalize that. So you are practicing in this setting and you're going to meet a patient. Okay, so you're in the hospital, you can do a fair bit in this hospital, and this is the scenario and the surroundings. Let's meet our patient, shall we? So our first patient is Johnny. He's 32 and he's a fisherman. He has been diagnosed with HIV/AIDS. Nowadays, we just really could say HIV, because in fact, I'll come on to some of the treatment. We start people on treatment even before they have what we might have called in the past an AIDS-defining illness. So HIV positive, and he's on first-line treatment. His sister brought him to hospital. He has a history of high fever and breathlessness. There's some twitching in his arm, but the major issue is a severe headache that has been there for several weeks, but becoming more severe. And he's agitated and very distressed. She's also noticed an area of purple skin, or dark skin anyway, on his face. Okay. Now, maybe you haven't seen many people with HIV/AIDS, and that's okay. But I want us, first of all, to think, what are the possible causes of his symptoms? And as you do this, I'm going to give us a blank sheet so that we can list some of these and see how you get on. To start to think of the possible causes of his symptoms. Okay. Now you may put it in the chat here, or you may even, here we go, tuberculosis, TB meningitis, cryptococcal meningitis, TB, excellent. These are excellent suggestions. Any other suggestions? So great, toxoplasma, Kaposi sarcoma, drug-induced neuropathy, pretty good list. So you're beginning to give me quite a good list of central nervous system complications, a few others that are more systemic. Anything else you want to think of? So pancytopenia, okay, so you're wondering if there's a bleeding problem, excellent. Liver injury, good. So you're now beginning to think of the vulnerable population, and there may be drug-induced challenges and pancytopenia, very good, very good. You can tell this is a very bright group. Okay. So what do you think about the holistic issues then? I've given you some clues. I know this is not a familiar scenario for you, but I've given you some clues. What are the holistic issues that you're seeing in this situation? So a young man, a fisherman, these terms may not mean much to you, but a young man is a fisherman. And these sorts of problems. What do you think the holistic issues may be for Johnny and for his family? So just getting to hospital might be difficult. Late presentation, it sounds like he's been ill for some time. To continue with the treatment, okay. So fishermen in Uganda, this gentleman would very much fit with anywhere around Lake Victoria, where I live, have been living. Often earn quite a lot of money, but in fits and starts. And when they have money, they tend to spend it, and they don't always spend it in the most wise way. But he could be the main income earner. We also know that these fishermen often go out onto lakes, dangerous behaviors, and they often do not comply with standard treatments. So, Sravani, thank you. Malaria is really important to think of. Poor compliance, excellent. So thank you for thinking of that, because he's on ARTs, but is he taking them? Antiretrovirals, hugely important. And one of the tips for you when you see patients is to think of adherence and compliance. We should think of it ever, always. And sometimes we use the word adherence just because compliance almost sounds like people are not compliant or they're compliant. But the reasons for non-adherence could be that you can't access it. It could be that COVID-19 meant the clinic closed down. It could be that that grant coming from USAID had finished and now there's no ARVs. It could be that he hasn't revealed to his family what's happening and therefore is not getting support for his ARVs. Maybe he's hiding it from someone. Excellent. Okay, we'll come on to support later, but thank you. You've explored quite a few issues. Let's look at some of them now in a bit more detail. So you did a good job. Well done with your differential diagnosis. You mentioned even one or two that I hadn't put here. But here's very common ones. So CNS infection, particularly in those whose CD4 count is low, that means their immune system is very vulnerable to particularly opportunistic infections. Malaria is top of the list. So you got there. I think that was Shravani, was it? You got there. But remember, with anything, whether it's cancer or HIV, it doesn't have to be the illness. It could be something else that's causing the problem. Bacterial meningitis, the thing that's different there, you're familiar with this one. It tends to be an acute onset. So short history and really quite dramatic neck stiffness and headache and photophobia. Sinusitis with odd infections is common in HIV, in immunosuppressed patients, and that can lead to brain abscesses. Cryptococcal meningitis, now this is the very typical one, but crucially, there is a slow onset. There has been a bit of a headache for a while, and then it becomes so severe the patient is really absolutely distressed. And this is the typical history of cryptococcal meningitis. And that's that test I told you about, the serum CRAG, that can get this diagnosis very quickly. Usually a serum CRAG is done, and then a TAP is done. And in fact, if it is cryptococcal meningitis with a kind of fungal web obstructing the drainage of the CSF, then patients can feel very relieved from having a pleural tap. And sometimes we do repeated taps alongside analgesia as pain control. TB meningitis you mentioned, or there could be a tuberculoma, and usually the fever goes with that. This person has a fever, maybe that's his problem. Toxoplasma, we have to differentiate that from other space-occupying lesions. You can see the CT scan here, typical ring enhancing of and more than one lesion. That's very typical of central nervous system toxoplasmosis. Cytomegalovirus, we look at the eyes and maybe a history of GI ulceration. We can get various forms of encephalitis. HIV itself can cause that. Good. Then, of course, other forms of HIV associated, like lymphoma, or non-associated space-occupying lesions. And just remember those ones at the bottom. Venous sinus thrombosis. In fact, a proclotting is more common than a pancytopenia, but thank you for thinking of that. But both can be there for sure. Or it could be unrelated to his HIV status, in which case we must think of pancytopenia as well, or something that's just reducing the platelet count, thrombocytopenia. Drugs could do that, most definitely. And then we think of other things like medication. That would include the ones that are prescribed and the ones that aren't. Syphilis is rearing its head. In fact, I remember I didn't go back and tell you at the beginning why certain populations were seeing an increase. We're seeing a rapid increase in Russia, in Ukraine, in the refugee areas of the Middle East, and we're seeing some illnesses that we have not seen for a long time emerging in those places. And that's why the face of HIV and the type of illness it is really changing globally. Okay, well done. You did well with that clinical scenario. Let me introduce an extra dimension to it. By the way, anytime you want to ask a question, just put the question in chat. I'll do my best to answer to you. It'll make you smile. When I'm teaching my postgrads or the medical students in Uganda, they get this list pretty well, but they would probably not get a very good list. If I said hemoptysis, they would tell me TB, and they would hardly ever think of lung cancer because we hardly see it. They would hardly ever think of ischemic heart disease because they hardly see it. So this is a very, very, very common list for a differential for a patient like that coming in. Let's have a look at this issue now, an ethical issue that you talked about before. Johnny's wife is pregnant with a 4-year-old child, but has not had any antenatal care. Sorry, pregnant and has a 4-year-old child. Never had antenatal care. Her mother-in-law is insisting she doesn't go to hospital, but wants her to have traditional birth attendance. And you are unsure if the wife knows her husband's HIV status or her own's, or the 4-year-old child's. What's your suggestion? There's some very obvious ethical issues. How are you going to approach them? Any suggestions? All them for discussion. Yeah, so I think trying to do that together would be very important. How we'll ask the person. So if the patient is not too unwell, we're going to speak to the patient. It's not an emergency to speak to the wife. So we would try and treat, I think, the patient and see if we can improve his condition and be able to talk to him about it. So then we'd have to think about the benefits of testing. It's a very interesting one, isn't it? How we handle this issue. It's a tricky one. See if we can think any more about that. Check the wife for HIV with her consent. Okay. So we're all in favor so far of counseling the wife and then testing her, but some of us would like to ask the patient first. I think we should all ask the patient first, shouldn't we? shouldn't we? But we do have a duty of care to the wife and the child. Now, this has been an issue for a long time in the HIV/AIDS pandemic. Do any know some of the ways people have addressed this scenario? You haven't mentioned, I think one of you mentioned it. No, nobody's mentioned it yet. Nobody's mentioned it yet. Okay, let me ask you another question then. Do you think before we do an HIV test, this is for the patient or for the wife or anyone else, we should counsel? And I'd like you to use your app, to all say either yes or no. Either yes or no. Should we counsel before doing HIV testing? And I just want you to say yes or no. So far, the yeses are winning. I was going to do all these little quizzes, but unfortunately, the system didn't allow me. Everybody's saying yes. Okay. Very interesting. So in Uganda, we don't counsel before HIV testing. And in fact, what Ugandans and many other places said was, we don't counsel before we do a blood count that might show leukemia. We don't counsel before we do a renal test that might show end-stage renal failure. We don't counsel before we do a hepatitis test. Why did we make HIV different? Was that part of the stigmatization? It's an interesting question. I think you can answer it in different ways. But the advice certainly from WHO is in a high prevalence setting, testing should be routine, just like you do for anything else. The disclosure of the results of a test, of course, must be done carefully. But we should do that just as carefully for somebody who has a biopsy coming back showing cancer, should we not? Or somebody that is showing that they have got a chronic active hepatitis, or a child that has got a Down syndrome. It's a very interesting ethical issue for you to think about as to whether we made HIV very different and therefore actually hindered testing. So, for example, in all areas where you saw most of those pictures of prevent mother-to-child transmission, every single mother is tested routinely for a number of things, for their hemoglobin, for their rhesus status, for their HIV status, for syphilis, and depending on your setting, how many tests are done. So one of the ethical issues in here, did we make it ethically more complicated by having this kind of super intensive way of making a diagnosis, which we don't do for other very, very serious illnesses? I wonder if you have any thoughts on that. For testing, we need to take consent. And so you have to look at your own laws. Is that a law or is that a practice? And if so, what is the difference between consenting for something like cancer tests or any other test? What if somebody comes in with blotchy patches on their skin, like we've just described, and we find out they have leukemia, but we didn't ask them in advance if we could consent to test for leukemia? It's a really interesting question, isn't it? And I think that's one of the things that I certainly saw. Routine testing was routine counseling and testing, then became routine testing. And in fact, they will say that everyone coming into hospital needs to have that done. There you go, testing before surgery. It's a very valid point. So maybe we should just be saying to people, we routinely test you for a number of medical conditions, which will include the following. So we don't specifically test that. I'll tell you a funny story. I had a respiratory problem a few years ago, which was quite severe. And I came back to my old hospital in Scotland, and this young doctor came to talk to me. Very sweet, asking me a lot of questions. What is it like living in Africa? I hear you were a consultant in this hospital for 10 years. And what's palliative care like? That's really interesting. What sort of illnesses do you see? And I was thinking, this is a sweet young man, but what is it he's wanting to really ask me? The poor young man wanted to ask me if he could do an HIV test. But the idea of asking a senior consultant, it was too scary for him. And I didn't realize that it was scary for him. So eventually I said, I think you're asking me about doing an HIV test. You must do it. I've been 10 years in Africa. You must do an HIV test. Do you see what I mean? We make it terribly complicated. So I just raised that ethical issue for you. Should you be doing this routinely? Maybe you'll find out it is being done routinely for patients in for antenatal care? And why is it that we made this very different? Something for you to think about. In Africa, I think what would happen here is you would try and get the consent for the patient, but you would actually make sure she comes from antenatal care, do a routine test, and then talk about that with her. But ideally, with the consent and permission of her husband. Not permission to test, but permission for discussing the fact that she may have acquired it from her husband. So that's the difference. You can find out the test, then of course what you do with that is a tricky issue. Well done, thank you for taking part in that. So let's look a bit more at some of the treatment guides now. We're moving from the global situation to the ethics and now looking at some of the care and treatment. I would strongly recommend that if you want to know the details of what to do in your setting, you find it out. Here's 3 examples from national settings, and here's this excellent WHO manual that I told you about. Here's your ones from NACO in India. They do have palliative care in there. It's been there for quite a while. Definitely worth looking at and being aware of and downloading for your setting. They do derive from the WHO, but you might see some things that there's discrepancies. I'm not going to go into the details of what it's like in, what drugs you use where. I'm going to give you the principles and introduce you to some of the overall issues to help you understand the illness and then think about how you apply your palliative care skills. And you'll notice I'm not teaching you the palliative care so much because you have looked at how to do that. So you apply your palliative care principles, your symptom control skills in the same way, but maybe the ethical scenario is different. Maybe the disease scenario is a bit different. Yeah, maybe you need to work collaboratively with your colleagues in HIV medicine or infectious diseases, just like we did in COVID-19. So here's some of the key issues in this journey. We've mentioned about testing. So routine testing is the norm in high prevalence areas. Prevention, hugely important. And there's now good evidence that people who have a lifestyle or behaviors that puts them at risk of HIV/AIDS may be eligible for pre-exposure prophylaxis. Okay, quite a controversial issue in some settings, but makes a lot of sense. It's a medical condom, if you like, a medical way to provide some protection to reduce the risk of transmission. We can talk about any of these issues if you want to. Post-exposure prophylaxis, we kind of know about that, both for healthcare workers, but also for those who might have been exposed. But the important thing to say is all of the regimes now are about undetectable virus load. If we have undetectable virus load, then the chance of transmission is down to very close to 0. And this is what's making the huge difference in the transmission rates and also in the number of people who are dying. Of course, we prevent and manage opportunistic infections and chronic illnesses. I'll come on to that. And then all of the supportive elements. So these are the kind of standard background managements. And I showed you that flow diagram earlier that covers a lot of these stages. Just to emphasize, undetectable is the aim. And we do check CD4s, but some people now just check viral loads, or some centers do viral loads plus CD4 count, because we want to know, is the immune system recovering, particularly when you start treatment and the immune system has shown that it's been suppressed, but also are we able to detect any active infection? And this is what's made a huge difference and should be making more of a difference even to things like stigma, because somebody with well-treated HIV infection can be undetectable viral load, can have a fairly normal life expectancy, although they have a higher likelihood of certain illnesses, and also is very unlikely to transmit, can go on to have children, and if they're a mother, to breastfeed, if their viral load is undetectable. And to do that, you need a lot of supportive mechanisms, not just the medication. Comment here, do you have a question? Very good, okay. So good. So Panita, you're saying, well, non-endemic regions of stigma. Yeah, okay. Okay, clinical setting. Okay, 2 very good questions. So the stigma is really quite low in most African settings now because it was always a disease of the general population. The stigma almost grew because of the populations that were affected in other places, but it can come back again. I mentioned about the HIV community. So men who have sex with men, it's very difficult for them to get the health care that they need. The routine is actually for healthcare workers to know the results of tests in high incidence areas, like you would know anything. And as you know, the bigger problem is actually things like hepatitis B. That's actually much more infectious and much more likely to acquire. So you should manage everybody with good health and safety processes. You should manage people with good infection control. You should manage any needle stick injury in an appropriate way. We don't have to take one group and say we do it more for them. We saw this with the respiratory-driven problems of COVID-19, but with bloodborne infections, we shouldn't be exposing ourselves by our way of managing health and safety. And therefore, it's quite routine for us to know what a patient's HIV status is in Africa. And I would suggest we should manage that confidentiality as we would for anything else. We should manage confidentiality appropriately between those who need to know, who are the primary carers, and we should be very careful and really never pass that on without the permission of the person. And we get round it for the children by doing routine antenatal screening. Does that make sense? Yeah, it's a tricky one. So we don't see, in fact, HIV/AIDS, some of our patients, and this will make you smile a little bit, often are more happy. That one person said to me, I wish I had HIV, but instead I've got cancer. And I said, why do you wish you had HIV? He said, because then I would get help to go to school. My medicines would be paid for. Can you see? Interesting, isn't it? In the UK, it's the opposite. People with cancer have a lot of support systems and things available to them. If you go to an African university, you'll see the HIV department is really, really nice. Lovely new building, looking very smart. And the cancer one is really in dire straits. And it's the opposite in the UK. It's interesting, isn't it? Just how these different diseases in different places. In India, I think cancer has a lot of stigma attached to it, a lot of stigma. And maybe we can think about stigma in general rather than taking one illness. And there's stigma around cancer that it's infectious as well. And people are scared to be alongside people with cancer, to drink from the same vessels. I think you will have seen that and been exposed to it. And we certainly saw stigma. And stigma, where does it come from? It comes from ignorance. It comes also from fear. So the more we are involving stakeholders in these discussions, the more we are involved in appropriate health literacy, and the more we are supporting people, they'll be able to drop these areas of stigma. Okay, let me move on a bit. So I've talked about this. Really, really important that you're aware of this. Undetectable. It's called the U=U campaign. Now, a little bit of background medicine. I'm just going to do this quite quickly, and I'm going to signpost. This is an excellent guide. This is developed for patients. It's also quite good for healthcare workers to try and help people understand ART, antiretroviral therapy. So it gives a picture here of a CD4 cell eating itself, because the CD4 cell is used by the virus to make more CD4 cells, which are then used by the virus. As the body produces more, the HIV goes to the next CD4 cell and again uses that to make more virus. So it's a self-replicating process. And this is a very nice, I think, pictorial diagram of what's happening. So you've got the HIV attaching to the CD4, then going into the CD4, then going into the nucleus. Various enzymes are involved, and these enzymes will be familiar to you because those are the enzymes that are being counteracted by most of our antiretroviral medications. Yep, reverse transcriptase, protease inhibitors, and the nuclear transcription enzymes. There's the protease ones are about how it's assembled into a new virus, and so on from there. So this is a very nice diagram. It's developed for patients. And I think this is a good example of how leaflets can be quite detailed. Of course, it has to be appropriate for your setting. And just mention ARVs, again, I really don't want to go into all of the mechanisms of actions. You can look that up. But you can block the entry into the cell. You can block the replication. Reverse transcription inhibitors are very common and are always part of our first line treatments. And then you've got these newer ones for integrase inhibitors, and then laterally protease inhibitors. So all of these, and what they do is they just attach to a different part of that life cycle, usually by inhibiting the enzyme that's involved in making that happen. Am I making sense to you okay? So, if you want to know more, download that book and have another look at the overall things. But that's really what you need to know. We prescribe these together because resistance can be a big problem. They're also more effective together, a bit like TB, where multi-drug treatment is the norm. And the actual regime is subject to a lot of research and change. So here's the current WHO advice for first line, showing that it's a couple of those are mostly using the first two ones, the transcription inhibitors, and then to second lines where we see some of those other ones coming in. The other ones, the integration inhibitors, are also here. Okay, and we look to see whether the person is clinically improving, whether their opportunistic infections are resolving or not happening, whether we can see a change in the CD4 count, and very important, in their viral count. I'm not going to talk anymore about the actual mechanics because in your setting, you will have guidelines. There will be national guidelines. I think your states in India use the national guidelines, and you have to use the national guidelines, and they will explain which ones for which settings. And nearly always they adapt them to the WHO guidelines with the one issue on access if some of the medications are more expensive. Happy with that? Questions there? So remember your life cycle. Remember all the places where you can inhibit enzymes that affect the HIV life cycle. Remember that the medications we're using are a combination usually of RT inhibitors and integrase inhibitors, and protease are usually used for second and third line. And there'll be more coming. This is a very active field of research. Now, interestingly, again, when I talk about stigma, I did some needs assessment in refugee communities in northern Uganda, and they told me, I wish I had HIV/AIDS because I've got liver disease and I can't get my medications here. And guess what? Antiretroviral agents are used for hepatitis B-related chronic active liver disease. So this situation is really interesting, developing and changing. And some of the knowledge we've gained from HIV is actually being translated into other infectious diseases like chronic active hepatitis. Okay, so we start our ARTs and we can get some problems. Treatment failure is usually, not always, but usually to do with those social and supportive issues. Toxicity is there, although with these combinations and careful monitoring, usually toxicity is much less than it was in the early days, but it still can be there, and it may stop people taking it. We may also have something called IRIS. Do any of you know what IRIS is? Any of you know what IRIS is? Just give me a thumbs up if you know what IRIS is, because I can see all your faces. No? Okay, again, I'm just going to give you a little bit of information about IRIS. This is something called immune reconstitution inflammatory syndrome. So I'll tell you the scenario. You give a patient ARVs and they get worse. Okay? They might get a lot worse. Now, your choice is there an opportunistic infection that you've missed that you're not treating? Is there some complicated drug interaction issue going on? Or is that this immune system was silent? So it's a little bit like you didn't know you had a problem because you haven't opened the door into 3 rooms in your house. And you didn't know there was a flood in one of them. There was infestation of rats in another one because you haven't opened the door, because you were stuck in your chair and you weren't able to walk. Suddenly you're able to walk and you start opening doors and all these problems are there. They were there already. You just didn't know you had them. So an immune system which is very, very suppressed can't even show an infection. Does that make sense? Can't show the signs of an opportunistic infection. So sometimes that's all that's happening. You're unmasking opportunistic infections. That's why we use a lot of prophylaxis. But sometimes it's actually something to do with an actual inflammatory process that is independent of that, and we need to manage the inflammatory process. So there's your little very, very, very introduction to IRIS. And that's all part of this treatment process I talked about earlier. Okay, so finally, in the last 15 minutes or so, HIV, I see some questions. Let me look and see what the questions are. Okay, that's a good question, and as I was saying that, Punita, I did wonder if it's like the cytokine storm. I don't think it's exactly the same, but many of the opportunistic infections cause an inflammatory syndrome HIV causes inflammatory syndrome. The weight loss of HIV is very similar to the chronic cachexia and anorexia syndrome that we see with cancer and with heart disease. So yes, chronic inflammation is at the heart of a lot of this. And chronic inflammation is something that we don't understand very well. COVID-19 has really taught us how little we understand it, but it is there in many, many, many illnesses. And remember, anorexia cachexia syndrome is almost always a paraneoplastic or para-illness syndrome caused by a cytokine-mediated problem. Very occasionally caused by a direct effect or by true malnutrition. Of course, in HIV/AIDS patients, they may be true malnutrition if they're in very poor areas. So this idea of what inflammation has to say to us, our bodies, is very, very interesting. And how do we switch it off? And we do know that in most illnesses, we can switch off the underlying illness. If we can treat the cancer, if we can manage the heart failure, if we can treat the HIV infection, then that inflammation will settle. A very good question and very interesting. Right, let's come on to specifics of palliative care. And I would say to you, it's very similar to other illnesses. Don't panic about palliative care at HIV. Use all the skill you've known. Pain and physical symptoms related to HIV or infection or its treatment, number one. Mood disorders and psychological distress, which are relating to the setting and the context as well as the illness. Spiritual distress. I was delighted to see this. This list is actually from the WHO document. And I'm really glad to see that because, as you know, we in palliative care talk about it, but sometimes it's missed out from other areas. But this is the thing I want you really to remember is, in fact, the biggest issue in most places is not Johnny and his problems that I described to you. It is somebody who is living with HIV/AIDS and is moving into a situation of chronic illness and multimorbidity. They're acquiring the chronic illnesses maybe 10 years earlier than somebody without HIV/AIDS. So you've got accelerated hypertension, heart disease, COPD, diabetes, and they will present to you in the way that, and cancer, certain cancers, they will present to you as you are familiar with already in palliative care. Again, this recommendation from WHO is to make sure that in palliative care, there has been incidences where we have not managed people living with HIV/AIDS and their problems as we should have done because of our stigma, our lack of access to care. I find it very distressing. I'm talking personally here when palliative care is only cancer. You know, I'm an internal medicine physician. Why should you get better care if you've got cancer than you do if you've got end-stage liver disease or HIV/AIDS? When I was a young doctor, I had to find a patch of Kaposi's sarcoma to enlist them in the palliative care program because it only did cancer. So please let us challenge those silos that we live in that mean that our patients have to fit our services rather than we offer the care that we need. Now, of course, that means many times we will integrate our care into HIV care, into internal medicine care, into sickle cell disease care. It doesn't mean we all have to do specialist care, but I've heard many of you tell me you're in family medicine, for example, and that's a very good example of integrated care. But I mentioned before about 12.8 million are thought to need palliative care, those dying, but also majority are living with it. There is a new health paradigm. You'll have heard of the Lancet Commission report on pain and palliative care, and that defines something called serious health-related suffering. And in that report, it estimated that HIV was accounted for 194 million days of serious health-related suffering. Okay, so it's a huge problem, not just the death and the incidence, but the impact on suffering. And as we've said, it's the end of life, yes, very important, but also living with HIV, comorbidities, biopsychosocial and spiritual consequences. And many are in low and middle income countries, like all of the health indices and health burdens, including non-communicable. And just a reminder here that children with HIV account for 30% of the worldwide palliative care burden in children. What models do we use? Again, this is not very new for you. This was the early model, wasn't it? A bit like the cancer model. We wait until there's a severe problem and then we look after them in the terminal phase. But this is really not the model we should work with in most of our palliative care problems. Many cancers have become more like a chronic illness if there's access to to treatment options if people present early. So this way of looking at intermittent periods of needs that may come along with toxicities, it may come with a comorbidity, it may come with a severe opportunistic infection. I mentioned the severe headache of cryptococcal meningitis, where absolutely we need to use opiates for that alongside regular taps, spinal taps. It may come with a biopsychosocial or spiritual crisis that comes alongside it. So our palliative care is given in conjunction with colleagues from family medicine, from HIV medicine, and the wider community. We look at, in our context, we must make sure there is prevention and prophylaxis, that we look at how we can shift the emphasis of care if something happens. And these are things to think about when you're assessing your patients. Maybe you don't normally think about prophylaxis, but do think about it. Because if we stop a prophylactic medication and then they get a severe opportunistic infection, that's going to be a big problem for their quality of life. But really, really important, let's think about the accelerated diseases of old age and how we should be prepared for that, both coming to our population with incidental HIV. It's not causing them a problem now. It is simply led maybe through some of those inflammatory pathways to accelerated HIV. Let's look at some of the figures on this. A couple of papers just showing high levels of anxiety and depression, even higher than cancer and diabetes, for example, in this study. And poorer quality of life in the general population. And the symptoms are not very different from the ones you're used to: breathlessness, nausea, vomiting, anorexia, fatigue, insomnia. The one that's a little bit different is diarrhea, will be more, depending on the cause of the problems. Pain in the last month, these are people well attending clinics, very high incidence of pain, higher than their normal population. And very importantly, quality of life and all domains was worse. Pain syndromes, very broad. The ones that you're familiar with, but the ones maybe less familiar with, some of the opportunistic infections, the antiretrovirals themselves, the HIV can cause a polyneuropathy, the chemo or the isoniazid for the other associated illnesses. Some of the infections can cause problems that make us breathless or cause pain. We've talked about headache already, oropharynx with ulceration and candida, generalized aches and arthropathies and myopathies. Pancreatitis is common. And we've mentioned some of the inflammatory cardiac problems. Now, I'm only saying this quickly because I think the main issue is, yes, you need to diagnose well, but the management is the management that you have learned, is step-by-step management, not rushing into using opiates if you can use other things to control the symptom. For example, treat the opportunistic infection, or change the medication, or adjust a lifestyle. But they will have a role, and we should use them as we would in our other populations. Being careful for those with more chronic illnesses that are going to live a long time, and being less concerned about some of those issues, substance issues in our other populations. You can use opiates in substance use populations, but you have to use them carefully in a structured way, and you have to manage the psychological and social supports well. This is a situation in South Africa. I just want to show you people coming with infectious diseases, what they were coming with, and it was TB, TB, TB. And then all of the other issues, including other forms of TB. So this is how, certainly in India, this is how usually our patients with HIV, if they're developing a problem, it's usually TB. But in India, you've got many patients who have TB who don't have HIV/AIDS, and you're very, very well aware of how to manage that. Remember that HIV itself has stages, although because we treat everybody, sometimes we don't see this change in stages. This used to be very common. Which stage is it? Have they had an HIV, an AIDS-defining illness? Now it's, if they're HIV positive, we put them on treatment and we try and keep them virally suppressed for as long as possible. And if that's successful, they will come to us with their cancers and their COPDs and their diabetes. And in fact, this is a very famous person in Uganda. He's a doctor. He developed, he was HIV positive in 2000. His CD4 count was one, the lowest it can be. And he had TB, cryptococcal meningitis, and Kaposi sarcoma. And here he is 23 years later as an advocate for HIV/AIDS. He speaks at really all of our events. He's such a well-known and very gracious man. And he is now campaigning about the fact that people with HIV/AIDS do not get these other treatments. All the funding has gone into HIV/AIDS and not into NCDs. And what are we going to do about that? Okay. So just a few tips as we get near the end, then I'm going to have a couple more cases for you to look at. Do your usual pain assessment and symptom assessment. Do your usual whole person assessment. Look at the current disease, but maybe you're going to think a bit more about what tests have been done before, what the history of their HIV and their antiretroviral therapy, and if you can find it out, how they've got on with adherence, what infections they've had before, what their viral load is. So those will be a bit different from your standard assessment. Be careful to look at the psychiatric comorbidities. You would do that anyway, I hope, in a good palliative care assessment, but think of them here. And remember substance use issues. And then think, are they part of a vulnerable population? And do I have some specific issues there? And is there specific issues around caregiver burden that I need to be thinking of? And how I communicate and manage the ethical issues. This is a lovely phrase my Arabic friends have taught me in Gaza. They describe spiritual distress as your world has been shaken. And the diagnosis of HIV, complications, and the stigma and so on, is a really good description, isn't it, of the spiritual distress we see throughout palliative care. Okay, so just a few examples and we're nearly done. And there'll be just a few minutes at the end for some questions. So here we go. In case you've fallen asleep, you can wake up and see this scenario. So this is a young woman, severe pain and distress. She has a headache for 3 weeks and an ulcerating rash on her face for the past week. What do you think might be causing her symptoms? Benita, sorry, I see the question there. Seroconversion rate in best case scenario. You mean going to, I think we can get, almost everybody can get suppression of the viral load if we treat them well and if we catch them early enough. Okay, Parul, you're saying wound infection, okay. Srivani, herpes, trigeminal neuralgia, okay. Trigeminal neuralgia, herpes zoster. Do you think there might be two problems? Many of this is a patient who has never had her HIV treated. She is HIV positive. Her CD4 count was only 100. So she's very vulnerable to opportunistic infections. So herpes, you've told us, and herpes with superimposed infection, kaposi's, possible. Anything else? Something in that history that I told you about earlier. CMV is a possibility. It is a possibility. Something even more likely? Meningitis. Okay, great. So that would be a very typical history of somebody with a cryptococcal meningitis picture and severe herpes zoster. Now you can see there, this is poor prognosis disease because the eye is involved, the cornea is involved, and the tip of the nose. The tip of the nose is involved. It means you've got an extra branch invaded because you get much broader, not just one nerve root, you get many nerve roots affected. And that shows that quite a lot of the nerve is affected. And this will be quite difficult to manage clinically and may involve the loss of her sight because of the corneal blindness. Good. Holistic issues, I think you'll be very familiar with these ones. Really bad. But I want to ask you one more question here. She told me this. She said, when I cry, I have pain. When I cry, the tears cause me pain. Why do you think that is? So I'm really testing your diagnostic skills here.
Lacrimal duct occlusion.
Tell me again.
Lacrimal duct is occluded.
Okay, possibility, but that wouldn't cause pain, would it? Very good, Carol. Very good. You're thinking fast on your feet here. So in fact, what she was describing was allodynia. It was, and you know, I sometimes tell my juniors when I teach them, you'll never forget allodynia. So the pain was so bad, she was crying. And when she was crying, the pain got worse because of allodynia, because of course, herpes zoster, very commonly associated with a severe pain with allodynia. So she had two pains. We could manage the cryptococcal meningitis with opiates and with treating the underlying infection and with TAPs. And we had to manage this with antineuropathic agents and really protect her face from her own tears. Bless her, this was a very difficult scenario. Okay, well done. Here's our first patient that I saw when we started a new unit. Again, this is an African scenario. So here's this patient. He's got smelly lesions on his legs and his face, known to be HIV positive, but not attending treatment. Remember, I told you young men are often the worst at adherence, particularly these fishermen. Some of the fishermen populations in Uganda had incidences of 99% positive for HIV/AIDS. What do you think is the cause of his symptom? These smelly lesions. I think you know this one. Widespread lesions all over his legs. I wish I had a picture for you, sorry, which are very smelly. No suggestions? This is typical of advanced Kaposi sarcoma. So, you get these lesions. And what was challenging here was a young girl had come in to help care for him, saw the look of the legs, ran away. He had no social supports because he had really used all his money from fishing to buy a lot of alcohol and indulge in behaviors or engage in behaviors that were very, very difficult. And he had really been ostracized from his family because of that. He'd not supported anybody in the family, and now they weren't really wanting to support him. In fact, his sister said to us that, when I can take his body for the funeral. Very difficult scenarios. Our job is not to judge, but to understand some of the social consequences. But I want to just let you see his quote. His palliative care, lying on his pillow, is actually the morphine that we gave him, a new blanket, simple things which are the bedrock of good palliative care. And his sense that actually the sense that he felt cared for, he no longer felt angry, he can sleep at night. And very interestingly, he now has hope. And hope is right at the essence and the heart of good palliative care, isn't it? Bringing symptom control, relieving suffering, yes, but actually bringing hope. And one of the things that he talked to me about was the way people had cared for him. He had been pushed to the end of the ward because his legs were so smelly. How did we manage the smell? Topical metronidazole. You know how to do that. Yeah, you do it well. And it's just showing you that you've got the skills, you've learned them, how to use them in this scenario to help young men like Swaibu. While you're doing that, teach your colleagues. This is me doing a round with our postgrads in internal medicine, where we've integrated palliative care into that in our university in Uganda. Why do I feel passionately about this? Yes, the patients are going to benefit for sure, but it's also going to allow those young doctors to learn how to do palliative care well. And this is a lovely quote from a young man who is now a gastroenterologist with an interest in HIV medicine. He says the person is a person, not a disease. He won't avoid difficult conversations. He won't do unnecessary investigations that maybe financially struggle, make the patient struggle. He'll see them as a part of the family. He then said to me afterwards, and it feels much better. So remember, we're caring for the patients, but also for each other and for our teams and for the next generation that are coming to help them do holistic care. And I'm going to let the last word be for another patient, Rose. She'd been on ARVs for 10 years. She presented with postmenopausal bleeding. And I think you'll know the cause, very likely, cervical cancer, stage 4. And I think this time you'll be very familiar, wouldn't you, the stage 4 issues here. So the issues of the disease, of managing the pain and the bleeding, of the sexuality and social consequences of this illness, of the access to treatment and how that's going to happen, of how we communicate and disclose and discuss, and how we break that bad news or have that tender conversation but maintain hope. But I want to also just finish with Rose's words. She had been an advocate for HIV/AIDS in her community. Very strong woman. When she was diagnosed with cancer, it was difficult to come to terms with that for sure. And the picture there is one of her nurses, one of our team, who incidentally was one of the first nurses in the world to prescribe oral morphine. This was allowed in Uganda quite a long time ago. And she said to me, I have been an advocate for my HIV. I now want to be an advocate for my cancer. So we said to her, well, actually, would you come to our national conference? So that was about 300 to 400 people, and speak about what difference palliative care made for your HIV and for your cancer. And she did just this. And I'll let you see her reply. She told everyone in the audience that palliative care had had a huge impact on her life, both in hospital and at home. She said it gave her hope, it gave her pain control, and it gave her love. And I think that's a great description of good palliative care. She then turned to the Minister of Health, who was attending the meeting, and said, make sure everyone has this care. And I think we would say the same to all of our policymakers and all of our settings. Let's make sure that everyone has that care. People with HIV, people with any illness who are suffering with serious health-related suffering. And I wish you well as you use the skills that you're learning and sharing in making a difference for HIV, but actually for all the patients and families and young doctors that you are going to be teaching and working with, and your multidisciplinary team and your community setting. So thank you so much. I think we've had lots of questions as we went through. There's probably just 4 minutes left if there's any last comments or questions that anyone would like.
Anybody would like to ask more questions?
I want to thank you for being very interactive. It was great to see that. And those who joined a bit later, maybe you'll have a chance to watch and share, but we did quite a lot of discussion and interaction. And I think, Sunil, I will give you the presentation and you'll make sure, or will you use it to show us slides? How do you normally do this, Sunil?
Yeah. You can send us the PowerPoint and we'll share with
I'll do that. I'll do that with
and
pleasure.
thank you, Mhoira. And that, as usual, your class is always very good and very interactive. I think the particular or you gave all the messages through case history, and I think that will remain in the mind forever. You were able to cover most of the aspects of palliative care, but I'm sure the specific aspects regarding HIV in India will be there in the module provided by Palliative India. So thank you once again, Mhoira, for helping us in this, and thank you everybody. And thanks our toast replay.
Thank you, Dr. Leng. It was really wonderful getting to know an eminent personality like you. I believe everyone would agree to that. And thank you everyone for joining in. And just reminding again that we will not be having a session tomorrow. This is Sripriya, along with Dr. Leng and Dr. Sunil Kumar, signing off from the Palliative India's presenter desk. See you in the next session. Till then, everyone take care. Keep spreading happiness. Bye-bye.
Bye.